So, welcome to Module 6 of Chapter 13 on schizophrenia. We're going to go over some of the frequency of schizophrenia and then the causes in regards to biology, social, and psychological issues. So, first, we're going to talk about the frequency. And what we can see is that there are some gender differences in regards to the overall frequency of schizophrenia. Now, I should say that schizophrenia occurs in about 1% of the population. So, definitely not the highest of our disorders, but it is not on the lowest end either. You can see the age of onset. Men are 30 to 40% more likely to develop schizophrenia than women, and they tend to develop it 4 to 5 years earlier than average women experience their problems. You can see the pre-morbid. That pre-morbid just means before you begin to see the actual schizophrenic symptoms. For men, you can see poor social functioning and more schizotypal kind of traits, whereas women tend to have better social functioning and not as many of the schizotypal traits. Typical symptoms, men have more negative symptoms. Remember, that's that flat affect, and more withdrawn and passive, whereas women tend to have more of the hallucinations and paranoia and be more emotional and impulsive. The course, unfortunately, for men is more often chronic, meaning it will go over a long period of time, and they tend to have worse responses to treatment. Whereas women may have less chronic conditions, maybe they characteristics diminish some over time, and they tend to respond a bit better to overall treatment. Now, if we go into the trends here, there's a graph that kind of shows over the course of time what we see as far as normal versus severe. And there you can see for the first 15 years or so, pre-morbid, that's the far left there, you can see mild motor, cognitive, and social impairments, but nothing to the point of a disorder. And then we get into prodromal, which we talked about, remember, about the different phases of schizophrenia, prodromal, active, and residual. And so what you see is kind of unusual or psychotic-like behaviors, and then you get the positive, negative, and disorganization in the onset, where you see the deterioration and the severity of symptoms really start to kick up. And then in those individuals with more chronic, you can see they do stabilize. You don't see them continue to deteriorate, but you also don't see them really improve a whole lot. Now, as far as whether this is a more culturally based disorder, something like eating disorders are very kind of culture based. What we see is that pretty much across the world, we see almost everywhere, we see schizophrenia. Frequencies do vary, as you can see, from 8 to 43 cases per every 100,000 people. And it doesn't seem like poverty plays a substantial role in the frequency, but it may go ahead and interfere with the relapse. And so we'll talk about that. There's a couple theories as to why we may see a little higher number of people with schizophrenia living in lower SES kind of situations than would be necessarily predicted. So let's go ahead and talk about biological causes. There is a lot of strong support for genetic influences. Your book's going to go into a lot more detail. So really what I'm going to do here in this module is just highlight a few of the genetic findings. If you're more curious about those, they're going to go into a lot more depth in your book and just really more time than I want to spend on it here. I think you'll get a sense of how much influence genes have on this particular disorder. Now, they have an influence on a lot of the mental disorders we've discussed, but I think schizophrenia is just one that they have a really solid research base in saying, yes, there is an influence. So you can see there in the first point about family studies, as the genetic similarity increases between two people, the risk for schizophrenia increases all the more so. So you can see with siblings, there's a 50% chance if a sibling has schizophrenia that you can get it too. Nieces, nephews, and cousins, there's about a 25% chance because you're sharing less of that genetic material. In twin studies, there was a really high concordance rate among people with schizophrenia. So the monozygotic concordance rate was 48%, and dizygotic was 17%. Now, remember, monozygotic means you're coming from the same cells and have the exactly same genes. Dizygotic means that there were two different zygotes, meaning that you have different genetic material, but you have the same type of environmental influence. And so when you see a disparity between monozygotic and dizygotic, it means that we can rule out that environment is likely playing a role compared to the genetics. So when you have a big difference like that, we can say for certain that there is a pretty decent genetic influence. And we can see this in the graph here too. You can see schizophrenia among children of twins and the percentage of risk. So here's your monozygotic schizophrenic twins, those that have the normal co-twin, the dizygotic schizophrenic twin, and then the normal co-twin. And so what this really goes and points out here is how the genes can really have an influence in regards to the overall occurrence. This next slide kind of goes into that too. So as you can see, general populace, very, very low kind of odds. If you're a spouse of a patient, you can see just a little bit more. Uncle, aunts, nephews, nieces, grandchildren, all of those are not as directly related genetically. And then you get into children who, of course, share half your genes, and all of a sudden the rates shoot up. Brothers and sisters, also, you're probably sharing an awful lot of genes in regards. Now, I'm not sure why children's listed twice on this particular slide, but fortunately they kept the odds about the same. And then you can see parents, there's decent, but then when you get into identical twins and offspring, with both parents having schizophrenia, you can see that there's just a very high risk factor. So it's one of the reasons why when we ask and do our very intakes, typically, we're going to ask about, is there a familial pattern of a particular disorder in the family? Because it does, as you can see here, especially with schizophrenia, put you at a much higher risk of developing than it would have otherwise. So, and that's really important when we get into diagnostics. Some other biological causes that are discussed, pregnancy and birth complications. So mother can contract a variety of diseases and infections that could influence the development. We call those teratogens, and it can be anything from illegal substance use to things like rubella or syphilis or other sorts of issues. And so what we see there, or if there are birth complications, and so did it take too long to deliver the baby? Was the baby breech, meaning that they were coming out feet first? Did you have to use forceps, which is basically a baby who gets stuck in the birth canal and then has to kind of get pulled out? Or did the umbilical cord get wrapped around the baby's neck, which of course can cut off oxygen, if not sometimes death? All of those are going to seem to have an increased likelihood of the development of schizophrenia. We don't really know why. It's just the trend that has been noticed. And of course, if you're given this many details, it's going to be really hard to go ahead and specify that. Just too many variables at this point in time, but they have noted the pattern. Getting into the neuro portion of this, and I am reluctant to dive too deeply into this, mainly because we just really don't have time to focus on the neurology, and you'll be getting into the cognitive psych course if you happen to take that. But it is important to note that there is this kind of neurotransmitter influence in kind of what we call neuropathology, and where the structures in the brain that are having difficulties or issues with any particular disorder at some point, and I don't think we're here, probably a good 10 to 20 years away, but at some point the hope is that we can do brain scans and some of these other techniques that we have in medicine to find biological causes of a lot of these disorders that we're discussing in this course. And we've gotten some good progress on it, but not to the point where we can simply stick you in a scanner and say, okay, you've got this. We just haven't gotten there yet. So we have to continue to use the observed behaviors. But you got to keep doing the research, and eventually we will get there. And so what they found with schizophrenia is that structural as well as kind of functional irregularities in the frontal cortex and in the limbic areas of the temporal lobe. And these are going to play a real important role in your cognition and emotional processes. So if you think about what are the symptoms that we're seeing here, so delusions, fixations, flat affect, all of that gets into cognitive and emotional processes. So it stands to reason if they have been able to isolate that to particular sections of the brain, that really ties in quite well. Now, there are a couple of neurochemical findings. The initial one was that schizophrenia was really a result of a kind of a lack of dopamine, or that the dopamine pathway was not working well in the limbic system. And it said maybe there's an elevated sensitivity to dopamine because there's more dopamine, postsynaptic dopamine receptors. And I'm going to show you in the next slide what exactly all of that means. But what the current thought process is, we can't just focus on dopamine. It's probably a more complex interaction between a variety of neurotransmitter kind of pathways. And at the current, it looks like some sort of interaction between the neurotransmitters of serotonin and dopamine is kind of what we're seeing most of. And so what we see here on your slide, just real quick neuro reminder, is you have a neuron, which is up in the upper left-hand corner there. And a neuron has a very long axon, which is an electrical signal that goes down anytime we have thinking going on in that type of part of the brain. At the end of an axon is what they call the synaptic cleft or synapse, and that's what the middle and bottom kind of are showing here. And what those do is they send little chemical neurotransmitters to the next axon to help fire that next axon in a particular way. And so with the dopamine, what the idea was is that they're overly sensitive because in the postsynapse, or the far right area there in that middle kind of illustration, is overly active. And so when you see that overly, like with too many transmitters, it means they get too much input, and that can create things and make it go a little haywire, resulting in these kind of more difficult types of behavior that we have witnessed with schizophrenia. Some other areas, just to kind of give you ideas of areas of the brain and the limbic system, and then some brain scans where you can see kind of the color difference between kind of a healthy brain versus one that's showing more schizophrenia. Now, of course, biology is not the sole dictator when we talk about influences on schizophrenia and the development of it. And so one area that people have spent a lot of time, because they have noticed that there does seem to be socioeconomic differences between those with schizophrenia and those without. Now, remember, they said it didn't play a role in necessarily developing schizophrenia, but it may play a role in its maintenance. And so the social class is an inverse relationship between that and schizophrenia. In other words, the higher the frequency, the lower the social class. Okay, and so there are two hypotheses to explain why that might be. The first one is a social causation hypothesis. And what this is basically saying is that the harmful events that come with the membership of being in the lowest social class play a causal role in the development of the disorder. In other words, being poor causes one to maybe become schizophrenic. And some of the reasons for that, that the people who use the social causation hypothesis explanation, is that stress, social isolation, poor nutrition, all of that can contribute. Now, there's the flip side too, which is social selection hypothesis. So this would say that people with schizophrenia are gradually going to fall into the lower social classes because they have that characteristic that I've harped on a lot when we do the diagnosis, which is social and occupational functioning. So if you have schizophrenia, by definition, you should have impaired social and occupational functioning. If you have that, you're not going to be able to do as well and get as much support as if you were in higher socioeconomic class. So the cognitive and social impairments endemic in schizophrenia therefore makes it impossible to get out of the lower social class because you can't hold a job, you don't have higher education, and all the other factors that would put you down in kind of lower social class standing. So, they go back and forth, and like most things, there's really no definitive answer. There's a little bit of evidence on one, the causation one, and there's a little bit of evidence on the other. So right now it's kind of mixed. And sometimes we just don't get clear pictures in psychology. It's a messy world, and sometimes we have messy answers to explain it, which doesn't make it any easier for us who are trying to find answers, because if you find answers, then you can hopefully intervene. Now, another factor of social cause is kind of the family relationships, something that's called expressed emotion. So the family environment does have a significant impact on the course, but not so much the onset of schizophrenia. So for a while there, they were blaming families for the occurrence of schizophrenia. As research has come out, they show that there is no rhyme or reason necessarily, other than maybe some genetic, on why somebody would develop schizophrenia versus not. Now, whether they relapse and how well their treatment goes is dependent upon family functioning. And so when they talk to family members, and there's families that have statements that reflect negative or intrusive attitudes towards the patient, what you see there is that there is much higher likelihood that this expressed emotion is going to predict a higher likelihood of relapse among patients with schizophrenia than if there are no family members necessarily in that emotional expressed kind of category where they're very highly critical. And criticism is the most strongly related to patients' relapse. But just to go to show you how important this factor is to look at for a lot of mental health recovery, is that expressed emotion is an even better predictor of outcomes for things like mood disorders and eating disorders than even schizophrenia. So it would behoove practitioners and people who are treating individuals with a variety of disorders to also find out family opinions about it. So, for example, if somebody with schizophrenia and there's a family member that feels like the person deserved it, or that because they did something and should have done something else, it's kind of their fault, and so they're always critical of them, that's going to make recovery all the more difficult. Now, here is some cultural differences between the various ethnicities in regards to expressed emotion. And you can see Anglo-Americans or white Americans tend to have fairly high, and then you see British, Mexican, and then finally Indian at the least. So it may get into even some of the acceptance of mental health issues and tolerance for differences within families in regards to that. So it's not all equal. So that's pretty much going to be just a very brief review of some of the schizophrenia and psychotic disorders as far as some of the causes. And so you can see there, the kind of flow chart, you have a trigger that activates this biological kind of component that we discussed, and those biological components can exacerbate social components and emotional cognitive influences, and finally the behaviors start to show up. And so it is a complex interaction. Even on this slide is a bit busy, and that is a simplification of all the factors that we have to look into. Good news is before we used to be able to do nothing for individuals with schizophrenia, but we've developed some effective treatments. Doesn't cure, but it can certainly help with their maintenance and allow them to have a more typical functioning life than be one that has to be warehoused into some sort of mental hospital or focused hospital. So that's what we're going to go ahead and talk about in our last couple modules, is how to treat either through the use of drugs or to also use some sort of psychosocial kind of treatment.